Hello, good afternoon. Well, first of all, let me just say thank you very much for this kind invitation to be in the 2VRT meeting. I miss, of course, not being in Lisbon, but the circumstances impede me to do so. And I'm honored to be invited to speak about this very important topic of non-obstructive coronary artery disease. It's obviously something that many of us have been interested a long time in this topic. Why is it possible that when we speak about the coronary circulation, we focus in those big vessels that are in the epicardium of the heart, while most of the circulation, as you know, is in the intramural segments of the heart, and account for most of the network, actually, of vessels that we have in our hearts. But, well, it's a knowledge that we have when we are at the medical school, and later we rarely had the opportunity to speak about disorders affecting the coronary microcirculation. And, you know, that's one of the big paradoxes of ischemic heart disease. I mean, how is it possible that we have focused so much in the epicardial vessels and we have ignored and, of course, not moved into treating patients who have problems in the microcirculation? But the fact is that it's a big problem. And if we just focus in one specific manifestation or consequence of microcirculatory disease, angina, we know that it affects a lot of patients. The most frequent scenarios probably are patients who have abnormal, geographically normal coronary arteries, but some evidence of ischemia. But also you may have it in the context of lesions that are hemodynamically not significant as judged by FFR or IFR, or also the patients who have angina after PCI. Now, a good example of this, for example, if you look to this very well-known paper by Manesh Patel, huge study population from the States, and you look to the patients who are sent to the cath lab for investigations for coronary angiography, and you select those patients who are the highest yield for angiography. That means patients who have angina, a positive exercise test or a positive ischemia test. You find that even in this selected population, more than 45% of these patients do not have obstructive disease in the coronary angiography. And if you look to post-PCI results, well, this is a very interesting paper. You know it from Nagel, looking to treatment strategy based on FFR or magnetic resonance. What I want to bring your attention is that in this, irrespective that you use MRI or FFR, rates of angina 1 year in this population, in this study population, was extremely high. So the ischemia and non-obstructive coronary artery disease, INOCA, has a huge impact in the life of the patients and also on the healthcare systems. I mean, typically these patients are stuck in a loop of never-ending tests. They have a very poor quality of life. They have disease uncertainty because no one is able to find what happens to them. Many of them are functionally non-significant stenosis. So what happens is that in many occasions, it's not rare to see that physicians decide to treat an stenosis that has an FFR of 0.85 or 0.90 because the patient continues having symptoms, and they are under the pressure of the clinical cardiologist for this. And also the fact that the non-obstructive coronary artery disease exposes patients to the risk of the microcirculatory problem that can be on the top of atherosclerosis. So INOCA is not a benign condition, and as we will see in a second. What I'm going to try to guide you over the next 10 minutes is basically the shifts in knowledge that have occurred in this particular field. And the first one is moving from the concept of syndrome X, which was in a way created in the 80s to express in a very eloquent way the fact that people were finding normal coronary arteries, but obviously signs of ischemia and symptoms. And at that time, because it was unclear the etiology, these patients were in a mixed bag. And it's obviously clear that if you put all these patients in a mixed bag, at the end of the day, you consider this is a benign condition. But nowadays, in 2020, we know that actually there are clear dysfunction pathways accounting for this syndrome. And when you actually have classify the patients according to objective evidence that there is something wrong in the coronary microcirculation, then you understand that this has a bad prognosis and also that can be amenable if you give proper treatment. This was one of the first studies that was providing evidence on this particular topic, is the WISE study, which basically was looking to women with non-obstructive coronary artery disease, following the patients over the time, looking to the subsets of patients who have normal coronary flow reserve or low coronary flow reserve. And as you can see, this study shows very clearly that having a low coronary flow reserve has prognostic implications in the long term. The other shift of knowledge that has taken place is that we move from trying to have a good physiological index, you call it coronary flow reserve, or you call it index of microcirculatory resistance, to combine tests. And to understand this, I think that we should remember that the reason because we use FFR or IFR in the epicardial vessels is because the main function of these epicardial vessels is conductance and distribution of blood to different regions of the heart. And for that reason, IFR or IFR, which are conductance indexes, can be used very nicely. But when you look to the microcirculation, the main mechanism function that the microcirculation has in the first place is regulation of blood supply, matching blood supply to requirements of myocardial oxygen. And for that reason, you need tests that are able to explore the dynamicity of the coronary microcirculation in this regulation, but you also need to have tests that look to conductance, because like the epicardial vessels, you may have a problem in the conductance of the microcirculation if the network has a loss of capillary density, or if you have thickening of the arterioles, for example. And that's the reason because in 2013, we came with this concept of applying a type of multimodal physiology assessment, where with FFR, you look to conductance in the epicardial vessels. With coronary flow reserve, you look to the dynamicity of the microcirculation. And with resistance, you look to actually conductance of the microcirculation. And by doing so, you are able to identify in these different quadrants, different subsets of, or if you want, phenotypes of ischemic heart disease. You have the phenotype of patients who have abnormal coronary flow reserve and abnormal fractional flow reserve, expressing that clearly you have a problem that is amenable with revascularization. But on the contrary, you identify patients where FFR is telling you that you don't have to treat the stenosis because the problem is located in the microcirculation. The third topic I wanted to discuss with you, and the shift of knowledge, is the move from microcirculatory disease to endotype of microvascular dysfunction. Speaking about microcirculatory disease is too vague. It's like if someone comes to you and says, I have a patient who has cardiac disease. I mean, you will immediately ask, what do you mean by cardiac disease? Are you talking about coronary artery disease, valvular disease, myocardial disease? The microcirculation may have many different types of dysfunction. And what matters is to identify the mechanism, the pathway of dysfunction, in order to understand what happens and to try to find the best possible treatment. I'm going to review with you some of these pathways of dysfunction using this conceptual map of the coronary microcirculation. If we imagine the coronary circulation like a series of resistances, where you have first the epicardial resistances of the vessels, typically very low unless you have a tight stenosis, and then the resistances of the arterioles, large arterioles, small arterioles, and then the capillaries. Well, if you think in this resistive map of the coronary circulation, you understand that there may be many different pathways of dysfunction. For example, in a myocardial infarction, you may have a lot of extravascular compression because you may have edema, you may have intramyocardial hemorrhage, you may have high left ventricular end diastolic pressure. You may have intraluminal obstruction, for example, if you have embolization of small thrombi or platelet aggregates. But in the stable coronary artery disease, there are two main endotypes of dysfunction. The first one is the dysfunction that is originated by vasomotor abnormalities that may happen both at the level of the epicardial vessel or the microcirculation. You may have microvascular spasm, you may have epicardial spasm. And these techniques are, these pathways of dysfunction can be nicely explored nowadays with the use of acetylcholine testing and also with the use of exercise. Let me show you this lady who had a previous stenting in the LAT and the diagonal. You can see that there's good persistent result of the intervention, but the patient actually was not relieved from angina after doing, this sophisticated two-stent bifurcation treatment. And this is what happens when I gave my first dose acetylcholine, very simple, through the catheter guide. And you could see that there was normal flow. But when we gave the third dose, you see this type of slow reflow, no reflow phenomenon or low flow phenomenon that happens at the same time that you have ischemic changes in the EKG and the patient had symptoms. And when we gave nitrates, of course, this evidence, these symptoms disappear. I'm going to play it again so you can see the effect of this 100 micrograms dose of acetylcholine. You can see that the blood is stagnant. You see the EKG changes and the patient had chest pain. Very frequent finding. And then on the top of that, of course, you can look to coronary flow reserve and microcirculatory resistance. We will speak about this in a second. So what happens in these patients typically is that you have endothelial dysfunction, which, as you know, is in many occasions related also or present in patients with atherosclerosis. And what happens is that instead of having an upstream vasodilatory the process, that goes from dilation of the small arterioles by metabolites to large arterioles vasodilated by the increasing flow, and then epicardial vessels, you have exactly the opposite. You have a fact that when you have an increase of flow due to small arterioles, because there is endothelial dysfunction, you have a spasm of the larger arterioles, and then this goes upstream, and you may even see in some occasions as these forms of diffuse spasm that actually reflect this collapse of regulatory flow that should happen in normal circumstances. And this is a good example, for example, an example of a patient who continued having angina after stenting. The stent looks perfectly all right, but as you can see, there is a major spasm distal to the location of the stent. So this clearly explains why you may have persistent angina in many patients, despite having a very good angiographic result. But on the top of that, you may also have problems in the microcirculation that have to do with the structure of the microcirculation. And this is something that we first, in 2009, we published this study where we correlated the findings of intracoronary tests with the findings in endomyocardial biopsies. And here you can see, for example, that the conductance of the microcirculation, which was measured with this combined assessment with flow velocity and pressure, we could find that actually was related to both the decrease in capillary network and also to the thickening of arterioles. Here you can see in that study one of these thickened arterioles that was associated with low microcirculatory conductance. And this is what happens in a patient. This patient had, let me stop for a second, hypertension, some degree of left ventricular hypertrophy, and she had a positive exercise test with chest pain and actually developing left bundle branch block. So the coronary arteries did not reveal any stenosis. What you see here is a guide wire fitted with Doppler and pressure. And here we try to mimic what happened to this patient during the exercise test by performing exercise testing in the cath lab. This is the setup we have. So we have 12 lead EKG in front of us. We have a cycloergometer in the cath lab. We have pressure and flow continuous assessment. And here you can see basically the results of the study in these patients. So at baseline, the patient had a coronary flow velocity of 41 centimeters per second. At the stage 2, and this is dramatic, there is no increase in coronary flow velocity. See, as you can see, flow velocity stays in 40. And the stage 3 of the Bruce protocol, flow velocity continues being exactly the same, 44 centimeters per second. But now the patient has angina, and she develops left bundle branch block, exactly as it happens in our cath lab, in the exercise tolerance test. So it was very dramatic to see this lady exercising in front of us and seeing that actually there was no increase whatsoever in blood flow to the myocardium. And here you can see the left bundle branch block resolving back to a normal ventricular conductance in recovery. So what happens in this patient? This patient has the other important endotype of microvascular dysfunction. Is what we call the structural endotype, the structural microvascular remodeling. She has, like in the study that I showed you before, perhaps thickened arterioles. Remember that she was hypertensive and she had some degree of left ventricular hypertrophy. She may have also some capillary rarefaction as well. But the fact is that the way of diagnosing this is, I showed you how to do it with exercise, but you can do it, of course, with coronary flow reserve, which will show a reduced dynamicity of the coronary microcirculation, and by measurements of resistance, because the conductance, the inverse of resistance, will be impaired in these circumstances. And we have different ways of looking to resistance. You can measure it with flow and pressure, like in the case that we were doing before, but you can also do it with thermodilution. Here you can see an example of how in this patient we are injecting a bolus of saline, looking to the pressure recovery at rest and during hyperemia. And with this, we can say that this patient has a structural remodeling because coronary flow reserve 1.6 is abnormal, less than 2 with this technique. And resistance, IMR, is very high, 31 units. We know now we take as a reference a value of 25 units as the upper limit of normality for these patients. And sometimes what you will see is that actually you have an overlap of these pathways of this function. So I just showed you the, so to speak, the clear endotypes, but of course, I mean, you may have some overlap of these different problems. Finally, the final part of my presentation is another important development. We move from cardiovascular events to patient symptoms. At this point, we learned with the WISE study that you may have more events in patients who have low coronary flow reserve. Can we do something for it? We don't know. I mean, what we know is that actually, if you have a patient who has low coronary flow reserve and you have high resistance in the microcirculation, is bad news. And we know it from this study, for example, from Korea, where you can see that compared with the other groups of that had a coronary flow reserve with low microcirculatory resistance, these patients are the worst, and probably are the ones that have a structural remodeling of the microcirculation. And the reason because we don't know if we can help these patients is because perhaps thickening of the arterioles, like you are seeing here, run along other changes in the heart. Like, for example, like you are seeing in this experimental model, the development of myocardial fibrosis. So in hypertensive coronary arteries, in hypertensive heart failure, for example, we know that there are problems in the microcirculation, but we know that also there may be concomitant changes in the structure of the myocardium, which perhaps are not reversible. We don't know. But what we know, and this is very important, is that we can help patients in controlling symptoms, and this is extremely important. And that's the reason because nowadays in the clinical practice guidelines, you have recommendations to use pressure guide-wise to measure coronary flow reserve and microcirculatory resistance, and also acetylcholine testing. You have both of them because each of these recommendations in a way is addressing the two main mechanisms that I explained to you before of dysfunction in the microcirculation in patients with stable coronary artery disease. So how can you help these patients? Well, if you have a structural remodeling, obviously the only thing you can do to help the patient is to reduce oxygen consumption. So beta blockers are the drugs of choice. If you cannot use a beta blocker, go for a calcium channel blocker that decreases myocardial oxygen consumption, or go for ivapadine or any drug that you think that may reduce myocardial oxygen consumption. And of course, treat any concomitant factor that may account for this structural remodeling, like, for example, hypertension. Give statins because it has an anti-inflammatory effect. What about if you have vasomotor disorders? Then you have to go for something that controls vascular tone. And of course, the drug of choice are calcium channel blockers, particularly those that have very strong control of vasomotor tones, like verapamil or diltiazem. You can use sporadically nitrates, but not on a regular basis because of tachyphylaxis and vasodilators. And it's important to give also ACE inhibitors and statins because it has been demonstrated that help to normalize endothelial function. If the pain is triggered by adenosine or iodinated contrast and you do not find any of the other two problems, consider that perhaps you have a proprioceptive problem or that you have an excessive sensitivity to adenosine. In that case, aminophylline, caffeine, tricycline, antidepressants may be helpful. This has not been as explored as the other previous treatments. In all cases, lifestyle modification and quantification of therapeutic progress with dedicated scales like the Seattle Angina Questionnaire. Now, the final slides. This good thing about this strategy is that has been already addressed in randomized clinical trial, the CORMICA trial, that demonstrated that when you treat patients according to this objective evidence of the pathway-specific function, compared with just guessing, you get much better control of angina and you improve the quality of life of the patients, both at 6 months, that was part of the CORMICA study, but also, like in this report from a larger series from Scotland, also at 1 year follow-up. And there's a very nice document I recommend you that was published recently by in European Heart Journal. It's an EAPCI consensus on document on angina and non-obstructive coronary artery disease, which basically summarizes many of these topics of discussion. So thank you very much for your attention. Again, if you're interested also in these topics, we invite you to visit the book that we wrote on this particular topic. Thank you.
Please, can you put the second question? What is the complementary assessment technique you prefer in your day-to-day? FFR, contrast FFR, B, IFR, C, PDPA, D, OCT. And right now, I will ask Dr. Pedro Braga to comment on the results and introduce the discussion of Dr. Xavier.
Knowing that some very, very high proportion of patients have no coronary artery disease, do you, in your daily practice, what change your approach of the patient? Do you perform to every patient this kind of approach, studying the physiology of the patient?
Yeah, so basically, obviously we've been doing physiology for a long time, and like in general, I believe the introduction of IFR was a big dynamizer, so to speak, a big revolution, a big dynamizer, because we had suddenly many new tools. All the colleagues, went really enthusiastic with the new possibilities of physiology in terms of longitudinal vessel assessment, co-registration with angiography, you name it. And it was fortunate, that in a way, although we had been working a long time in the microcirculation, all these came at the same time. So I know that my center is a bit special in that, but there are two patients that have rocketed over the last couple of years. One of them is TAVI patients, and the other one is non-obstructive coronary artery disease. I mean, we do many patients. And we've been very successful because it is the clinical cardiologists who ask for these type of examinations. Remember that for them is absolutely great, because they request this information, they set the treatment, and in a way they get the glory of having therapeutic success. And it is extremely, extremely, rewarding to see someone who has been, without a solution, having 4 cardiac catheterizations in the past, you name a few tests of ischemia. Nobody was able to find what was causing the chest pain. And suddenly that you are able to give something that is relieving the chest pain and improving the quality of life. It's very rewarding. And as you know, there's fortunately, we are now at a moment where there is a great interest in the medical community on this topic. So
it changed a lot your daily practice. It changed.
Yeah, and the good thing is that this technique, once that you implement it, is very simple to do. It's very simple. So you can do it even in a patient who is sent for coronary angiography, a diagnostic coronary angiogram, and you find that when you start making the first shots, you realize that perhaps there is no coronary arteries, and you can already tell your team, your nurses, I think that we are going to do an acetylcholine testing in this patient, and can you prepare a pressure guide wire, to measure flow, etc. And in total, it will probably add 20 minutes more to the whole thing, which of course is peanuts compared with all the problems that you solved for the patient.
Okay. Do you have some questions from the panel?
So we have Dr. André Luz remotely. Dr. André, do you have any question? Well, Dr. André, are you listening?
Yes, I don't know if you can listen to me.
Yes, we can listen. Now? Proceed, please.
Javier, it's always refreshing to listen your talks on coronary physiology. I have just a couple of questions to pose to you. Firstly, is due to TAVIs and aortic stenosis. How can we interpret? How can we study coronary physiology facing tremendous afterload imposed by aortic stenosis, just to know if you should revascularize or not those patients? And the second question is how to reconcile the FFR, for example, in STEMI patients, in patients with suffering myocardial infarction, because from a physiological standpoint, I think for me it's very difficult to understand and the benefits of doing any kind of physiological measurements to treat, for example, some remote vessel falling in the subacute myocardial infarction, especially due to the microcirculatory environment imposed by the inflammation and the ischemic reperfusion injury. Thank you.
Thank you. No, very, very interesting questions. I think that in both cases there is a void of knowledge. I think that the interest in TAVI or aortic stenosis is going to increase with the indication of TAVI in younger patients. For the time being, in the elderly, we still do not have clear evidence that revascularization improves outcomes in patients with TAVI. So you could argue that we need more information even to know if revascularization in the elderly is really required or not. But with younger patients, I'm sure that we are going to need this, because you really need to, in advance, anticipate this, because you will need to do something. As you say, I mean, probably FFR or the pressure guide wire indexes, which are affected very much by boundary conditions, which are, as you mentioned, going to change dramatically once that you place a valve, are not the ideal or the perfect indexes. As a rule of a thumb, if you have an abnormal FFR in someone who has aortic stenosis, that means that the stenosis is significant. But you have more difficulties in those that you find that the FFR is non-ischemic. It could turn to be ischemic once that you implant the valve. But again, it's an area that we need more information. For patients with acute coronary syndromes, something similar happens. We know that deferral of revascularization in patients with acute coronary syndromes is associated to slightly more events than when you do it in stable coronary artery disease. But I think that what is going to, the area of physiology that probably is going to be increasing over the next 5 years is the physiology of the culprit stenosis. The use of physiology to understand, particularly in STEMI, whether the patient has major problems in the microcirculation after you have opened the culprit vessel. And I'm saying this because, we know that what could modify the outcome of patients with STEMI is something that is able to prevent this phenomenon that we call non-reflow, microcirculatory non-reflow, etc. So I'm sure that we're going to see a lot of research in this topic in the future.
So thank you. Dr. Ana Rita, do you have any question?
Thank you. Thank you. Thank you for your presentation. I think I just have one comment. I think that I talk for all the Portugal, I don't know, but I think we need to test these patients and we need to start looking for these alterations routinely in our cath labs, because how you showed us that we have treatment for this patient. So you need to identify these patients in order to treat them. And if you are not happy with the available treatment, you need to identify them for test new drugs, I think is my comment.
I fully agree. I think it's very important. A strong limitation is therapeutic nihilism. I mean, many colleagues, thought, well, if I have an stenosis, I can treat it, give me a stent, But if I see microcirculatory dysfunction, there is nothing I can do. Actually, there are things that you do. And again, I think that, as I mentioned, this is something that is going to bring physiology out of the cath lab. It's going to be requested by the clinical cardiologist. I'm positive about that. And, and then we interventional cardiologists will be, I hope, delighted to collaborate in improving the quality of life of these patients. But it will be the clinical cardiologists who will be using this information.
Can I ask you, do you have some kind? Can we study a patient physiologically with angio-CT, for instance? There is some kind of new studies that show that with study physiology with angio-CT, we can have some kind of good response to these questions. What do you think about it?
Yeah, so this is something that happens in many occasions. I mean, for example, you see people saying, well, PET is the gold standard. Well, I say, well, for example, in myself in Madrid, if I want to make flow PET, there is not a single center in Madrid that is making flow PET. We have metabolic PET, but we don't have any flow, any center that is performing regularly flow PET with radioactive water or with, with any of the isotopes you need for this. So, but more importantly, which is important, I tried to explain this before, there is not such a thing like microcirculatory dysfunction. So MRI, PET, the technique that you are describing will never explore vasomotor dysfunction, for example. And for vasomotor dysfunction, you need acetylcholine testing for the time being, because cold exposure tests or hypercapnia or whatever, these techniques are, very. You cannot trust, actually, the testing of vasomotor disorders with this. So for the time being, the fastest and more exhaustive way more comprehensive way of looking to different mechanisms of dysfunction is intracoronary testing. But you are right. I mean, you could get some information based on this, on these techniques, particularly on structural remodeling.
Okay, this discussion is going with great interest, especially for the patient's quality of life and symptomatology. I will ask Dr. Rui if he has any question.
Javier, thanks a lot for your presentation. It was wonderful because I think most of us did learn something, or at least I would say. But at the bottom line here is that I'm going to pose you two tricky questions. The first one is, why, if we are not going to do an intervention, why can we not design a protocol that will test several drugs one after the other until the patient has a good clinical response? Because at the end, these patients come to our cath lab because they have angina, and if at one of these steps we can solve the angina, we can have the final solution without an invasive angiography with several steps ahead. I'm not saying that I'm not interested in this, because I think we are clearly moving on to study patients, as you mentioned right now, but this is a provocative question. The second one is completely out of this box, is do you foresee any technical refinement in functional assessment that will help us to define the patients that have severe aortic stenosis, normal ejection fraction, and in those patients they have no symptoms, the ones that we can eventually treat without any symptoms based on some physiological assessment? Thank you.
Thank you. Well, I think that as cardiologists, we try to base our treatment in techniques that provide us objective evidence. I mean, if the idea of you are saying, okay, let's forget about objective evidence, just try. And if something that doesn't work, just try another thing until you find something that works as an alternative of reaching a diagnosis. Well, I think it's very provocative, but I don't think that is very, realistic. And I can tell you, for example, that it will be not realistic for many different reasons, but one of them is because I don't think that, at least in Spain, we don't have a healthcare system that will be able to look meticulously, for patients and trying the next and the next and the next. So I think that at this point, finding a diagnosis is very important for the patient, for understanding if the patient has a particular risk, for tailoring the treatment. Personalized medicine will be more and more important, and this is my answer to your first provocative question. And I know that you were trying to provoke some debate. The second one, I'm not sure if I truly understood. I know that you were talking about the physiology of aortic stenosis. Yeah. Can you repeat it?
I can rephrase. What do you do if you have a patient that has a severe aortic stenosis by echogradients, that is asymptomatic in class 1? Do you anticipate that you can use some sort of physiological assessment to help us to decide if that is the patient that should go for AVR or TAVI instead of being on clinical follow-up as it is used today?
Well, for the time being, we don't have such a test. But actually, if you look into the literature, you may find a very interesting paper. It was actually the reason because I started to work with Justin Davis. So Justin Davis in 2006 wrote a very interesting paper that was looking to what is called wave intensity analysis in patients with aortic stenosis. And he found that actually, an interesting aspect of patients with aortic stenosis is that the degree of left ventricular hypertrophy, which at the end of the day is something that plays an important role in the outcome of the patients as well, is very variable. It's very heterogeneous. Some patients develop a lot of aortic stenosis. So you have the interplay between aortic valve area, left ventricular mass affected. And in this test that he developed, he was able to look into the microcirculation and look into the way that the capacitance of the microcirculation was impaired. You have to look to the paper to be able to, in a way, predict from a physiological standpoint those patients with aortic stenosis that had a major impact on the heart. But as I say, it's very academic. It was left there for the time being. Unfortunately, we don't have a physiological test that will be summarizing the effect of aortic stenosis on the myocardium.
Thank you, Javier. Wonderful. Thank you for your participation here.